Do have one more. I'm sorry.
So this particular lecture is going to be, hopefully you guys have taken a small look at it ahead of time. If not, that's okay. It's not okay, but it might be okay. All right. If so, in general, in a nutshell, this is going to be all of the emergencies that we see on a regular basis. What this is not going to be all of the weird, some of the weird stuff that we don't see on a regular basis that we run into occasionally. So some examples of that are some of these chronic conditions that affect people's ability to ventilate or move air or breathe or whatever the case may be. We're not going to see a whole lot of that. We're also not going to see a lot of the chronic patients in this particular lecture that have specifically pediatrics that are vent dependent, or some of the lecture or some of the things that are going to affect the ventilatory drive secondary to something else. So an example of that, down into the medical world, some of these weird adrenal insufficiencies, some of these adrenal problems, they do affect the ventilation pattern and the respiratory rate of some of the patients that we're going to deal with. We have to treat the respiratory problem, but we do that by way of treating the medical problem, and then everything else will self-correct. So I don't want to get down into those rabbit holes until we get into medical. So today it's just the organic, very traditional, specific ventilatory and respiratory issues. So that's sort of what that's pretty much what we're gonna do. A lot of this is going to come from the slides. And again, I'm not a slide reader. You guys know that by now. But some of the stuff on here is really good. Some of the pictures are really, really crappy. So we'll kind of bump through some of those. But respiratory diseases in general, they are one of the most common. We get trouble breathing on a regular basis, and trouble breathing can mean a whole bunch of different things. And that's part of what today's going to be. So epidemiology, and really all that means is the process that some type of disease takes to affect the body. So we're going to talk a lot about asthma and COPD because those are the top two. Those are the top two that restrict the actual ability to physically move air. There's like 15 million people in America that have COPD. So this is a very, very common thing. There's like 25 million that have asthma. So, and again, you don't need to write that stuff down. But if you are keeping notes or in a spot where you can keep notes, I'll let you know when some things that are really reasonable to write down come about. But there's, out of all of those millions and millions of people, 500,000 of them are regularly hospitalized for this annually. And about 3,500 deaths happen annually. And this is as of 2018. So we end up with, again, this is just a very, very common thing. We'll talk a lot about pneumonia. Pneumonia right now mimics some of the COVID stuff. So we kind of blend those as we move forward. But it's one of the most common fatal illnesses, and in quite a few of the countries, as it relates specifically to the respiratory system. And a lot of that has to do with the infection. So we treat the airway. We need to treat the infection, but we can't pre-hospital. So people will think they have an upper respiratory infection or something, and they'll stay home. They become septic. They go down the septic shock route, and they end up dying. And this is, again, more of the at-risk population. But there's roughly, like, as far as pneumonia, if you think about all of the inpatient units in the country, about 6% of the inpatient deaths in the United States come from pneumonia. So 6% is actually a pretty high number when you can say of all the things people die from in the hospital, 6% of it is just pneumonia. So a lot of that really is just going to be us having that ability to find that, identify that. And again, the hospital is going to do the same thing. So for us, it's really just making sure that the ventilation, just in general, their ventilatory system is intact, and that we support it as best we can. So some of the A&P, so they like to use this upside down tree. It is kind of an inverted tree. It's kind of what it looks like. You can see in the pictures, there's the main trachea where it bifurcates. This is called the carina. There's a left main stem that goes into the left two lobes of the lungs, or the left lung. The right side, again, there's 3 lobes. Again, the last lung lobe on the left is cut out because of the heart sitting there. And that picture is anatomically slightly incorrect. That right main stem is more vertical than it is at that 45-degree angle that you see there, which again kind of goes back to the why everything right main stem, why we end up intubating that on accident. So that breaks down into some of the, and we'll talk here in a minute about it, but the bronchial tree in general, there's a bunch of different terms. Alveoli, when I start talking about the alveoli, we know what that is. We've talked about that. We've talked about what that is. On the inside of the alveoli is a capillary bed, just like everywhere else in your body. So your fingertip, if you take a blood sugar, you poke into that capillary bed, you get some kind of blood flow. You get that capillary blood flow for us to do our sampling. That same capillary system is embedded on the inside of that alveoli. So again, the gas exchange happens there. So the body offloads all the carbon dioxide. It onloads all of the oxygen that comes in from the ventilations, and all of that absorption happens within that capillary bed into the blood flow or in the blood system. Tracheobronchial tree. So this is basically the trachea. This goes down, obviously carries air to the lungs. It's about 4 to 5 inches from the larynx to the right main stem. So in general, we're not dealing with a very large piece there, but we know that that's the connector. And I'm going to skip through some of the basic A&P that we already know. So the bronchi, there's a left and a main stem bronchi, and that connects the main branch into the lobes of the lungs. We're pretty familiar with that. As you get down into the tertiary and some of the other ones, they'll break this down, but basically this is kind of the flow in order once you get down into the small little tiny vessels and the small little tiny bronchioles that end up breaking down into there. Within the bronchioles, we're going to find that's a lot of the magic happens the lower you go. Which is why when people are when they have fluid or when they have any kind of edema in the lungs, a lot of that is stunted. A lot of the breathing is stunted because those small little openings, those are what's getting clogged with the fluid. So we'll break some of those down here in a minute. So the gas exchange, this is basically what I just said, but just a complicated picture to look at. So once you get way down in there, way down into the bronchioles, we know that there's capillaries. And again, that capillary, the capillaries, that is tying the actual gases to the bloodstream. And that's where that physical exchange happens. Now, again, those alveoli, they're receptive to the air, and they're able to pass air and gases back and forth. But again, that all of the magic physically happens in the capillary bed within that bronchiole, and that's where the CO2 and the oxygen, that's where those end up making that shift that's vital for us. Any questions on that? Hopefully that's kind of a review, but that is really, really important for us to know, for us to understand kind of how that works. All right, so the bronchioles. So cilia in general, cilia is they're like these little fine hairs. They're really, really, really tiny. Sometimes they have the ability to vibrate, and that's what allows us to kind of cough up some of the mucus. So with way down into the bronchioles, there isn't any kind of cilia. There is no way for the body to protect itself from the mucus that's hanging out in there. It also doesn't have the ability to take care of any foreign bodies that come down in there. So any kind of foreign body that gets lodged down in there, whether it be something in the airway, or on the other side, on the blood side, something in the blood, or something in the vascular system leading to that capillary bed, that we have no ability to clear that. So we'll talk about these embolisms, these pulmonary embolisms. We'll talk about these later, but that's a fatal condition, or it can be fatal if something lodges down in here for obvious reasons. So then, moving back up some of the smooth muscle that surrounds some of that area, really a lot of the smooth muscle, they do have the cilia. It does have the ability to vibrate, and for us to be able to form a productive cough from there. But that's really the big difference, is the bronchioles have no ability to self-protect themselves. So these actual alveoli. So there's like 16 to 24 of these little tracheobronchial tree branches, I guess. There's in general, this is pretty much where the air stops, and that's really the important part here. The alveoli is where the intake air, where that physically stops. And again, it's covered in capillaries. It participates in gas exchange, and there's nothing really super special outside of that. So the mediastinum. Now, again, this is back to A&P. So we're moving back out. So we're out of the bronchioles. We're actually into the space in the middle of the chest. The mediastinum is the area that pretty much contains all of this stuff. barotrauma, any kind of trauma, a horse kick to the chest, any kind of steering wheel, in the car wrecks. The mediastinum is the area that we're usually concerned about. So it is a closed system in there. In obviously the heart, the large vessels, the aorta, the aortic arch that comes up out of the heart and goes down into the body, that hangs out there. Obviously all the airway stuff. There's some pretty significant organs that go down through there. So we kind of worry about, so when they, with the trauma patient, again, if you think about that aortic arch, the heart physically hangs from that aortic arch. And it allows it to kind of beat and pump and move, but it also allows it to kind of sway back and forth. So, in general, the rules of energy passing, if you're going 35 miles an hour and you hit a tree and you physically stop, everything inside your body is going to continue to go roughly 35 miles an hour until something stops it. So usually what we end up seeing is that heart it'll kind of flip forward with that impact, and you'll have a small tear in the aorta in that arch where it's physically supporting the weight of the heart. So a ruptured aorta, obviously, we know that is probably fatal in short order. It doesn't take a whole lot of time for somebody to bleed out from there. But also with blood, we're also concerned with air. So again, this is a closed system in here. So this whole compartment is relatively closed off. So some kind of traumatic injury to the chest, we're also worried about air that gets trapped in there. And we know that the prefix for air is pneumo. So we'll talk a lot about pneumos. So pneumomediastinum is the term for air in the mediastinum, which is kind of obvious when you think about it, but that is a condition that we have to kind of look out for, and we can treat and fix in some cases. So the pulmonary blood flow, we know, if you go think back to the heart, think back to how the heart physically works. Blood flows from the heart to the lungs, goes out via the pulmonary artery. The pulmonary artery branches into some smaller vessels until those capillary beds end up getting what it needs down deep in the bronchioles. Once the gas exchange happens, it goes through the alveoli, through the capillary beds, into the bloodstream, and then it ends up going back into the heart from the pulmonary vein. So that pulmonary vein is now oxygenated, all that blood inside, because again, it just came from the capillary beds in the lungs. So it's going to cycle back into the heart. It's going to dump back into the left atrium, down in the left ventricle, and then pump out to the body. And you guys pretty much know how that goes from there. So the pulmonary capillaries, they're very narrow. The blood cells, they typically pass through kind of in a single file line. If you need a visual, they kind of go through in a single file line. Patients with chronic lung disease, so your COPD patients, generally just the COPD patients, or the anybody that's chronically hypoxic, something like that, the body tends to generate more red blood cells. So those particular patients, so let's go back to the COPD patient. The COPD patient can't physically oxygenate very well because a majority of the alveoli are damaged or broken or not accepting air. So the body says, well, there's not enough air. So we obviously, there's not enough oxygen floating around. So if we produce more red blood cells, we have more hemoglobin. And if we have more hemoglobin, there's more opportunity for the oxygen molecules to attach to something. The body doesn't necessarily know that the problem is not that there's not, it's not a lack of hemoglobin. It's a lack of the ability for the body to physically absorb the oxygen. But again, the body's kind of dumb and it doesn't know that. So all it knows is we're just going to create more. So what ends up happening is you end up creating more red blood cells. That makes the blood kind of thick, which is that polycythemia at the bottom. It's thick blood. And you can imagine how thick blood can negatively affect the body. Everything, it's kind of like the oil in your car. The thicker it is, the harder it is for the car to physically move that oil around. So again, the body is kind of self-destructing. It produces the red blood cells. The red blood cells make the blood thick, and the blood thick, it ends up taking a lot more effort to push the blood, that thick blood, through those pulmonary capillaries, and it ends up straining the right side of the heart. So again, think about the thick blood. You got this thick motor oil running through right side of the heart, the right ventricle. It squeezes, goes up, goes into the lungs, and you're pushing this big heavyweight oil through the capillary beds. And again, it takes a lot more pressure to physically get it through there because it's thicker. So it's putting a strain on the right side of the heart. This is where heart failure comes from. It's that overworking of the right side of the heart to try to pump that thick, nasty blood into those capillary beds in the bronchial tree. So right-sided heart failure is fairly common in the COPD patients, just simply because of that. Um, so that's something that we're going to see pretty regularly with these COPD patients. So also that additional red blood cell, all the additional red blood cells, is going to kind of create this kind of a red. They're going to kind of look pink. They call them pink puffers, and we'll talk more about that here in a little bit. But they have a general, if you look at a true COPD patient, they'll have like a barrel chest, and we'll talk about this too in a minute. But their skin is always going to be kind of that flushed, kind of that red pink color. So let's take, it's 9 o'clock. Let that sink in, because that's a pretty important milestone for us to hit, for us to kind of understand how that works, so that we can figure out kind of how we need to treat it. So let's take a couple minutes, get you some coffee, and I'll see you back in just a minute. All that other stuff, that didn't mean anything. That was all garbage. That's my story, and I'm sticking to it. I think that's really about it for that. So advantageous breath sounds. So advantageous breath sounds are basically the extra stuff that you hear on top. So this can be grunting. This can be any kind of noises. This can be fluttering of something that's in there that you don't really know what it is. But basically anything over and above a regular clean breath sound is advantageous. So if it's an asthma patient that's wheezing, that is an advantageous breath sound. And you can document it as wheezes. You can document that as patient had advantageous wheezes, if you want to throw that extra word in there. But really all that's meaning is that there's something on top of regular breath sounds. So wheezes are, so we know what wheezes are. It's kind of that high pitched, it's kind of a whistling because air is physically being forced through a swollen, narrow airway. They can be diffuse. So like with asthma, it's pretty much wheezes everywhere. If there's something down in the airway, so again, I decided to write main stem, some airway obstruction or something. If I listened to down in the bases, that may be very, very localized, where I can physically only hear wheezes way down in that lower lobe where I stuff something. Otherwise, like asthma, again, it's swelling everywhere. So you're going to have that diffuse swelling pretty much everywhere. Crackles is basically, again, this is just air spaces that are kind of popping open. You'll hear that. So again, those alveoli, they're kind of closed and they're kind of shut down because there's usually fluid or something over the top of them. When the lung starts to expand, they try to pop out, and that physical popping of those alveoli, that's physical airspace opening, and it's just like bubbling in water. It's the popping open of those alveoli to accept air in. So that's typically what you're hearing when you're hearing them crackles. That's usually associated with obviously with fluid in the lungs. Rails, again, it's typically those high pitched crackles, but it can be down in the base of the lungs. And that's usually heard kind of at the end of inspiration. So at the very, very end. So if you have bronchitis or anything like that yourself, sometimes when you take a real deep breath in, you don't hear or feel that the popping or the crackles until the very, very high peak, when everything's super expanded in there. That's Rails. That's exactly what that is. And then rhonchi is basically secretions everywhere. These are just nasty lung sounds, and that's the best way you can just explain it. They're just nasty everywhere. Sounds like they're underwater. It doesn't really matter, inhale or exhale. That's usually secretions in some of the larger airways. Some of the other stuff, the stridor is that high pitched wheeze from an upper airway obstruction. Grunting is basically a lower airway problem. Again, it's them trying to get rid of some of that carbon dioxide. Death rattle, that's a term that the book likes to use and nobody else uses, but basically it's like a gurgling noise. It's essentially, it's essentially just it's a gurgling. That's really the best. There's no real air movement. It's agonal. Agonal ventilations is what that really comes to be. I think that's really about it. And obviously, no sounds. Well, that's ominous. We know that. We just talked about that. Sputum. So we're still looking over the patient. We're still trying to figure out what's going on. The color or the amount of sputum that they're producing, has that changed? Is it blood tinged? And that's something kind of important to think about. So if they're coughing up some kind of discolored sputum, so we try to figure out the color. If it's like a brown or a nasty kind of color, we know that can mean a couple different things. But kind of the brown, that nasty, that nasty funk kind of thing, is secretions in just various stages. So basically, it's probably a little bit of pus, it's probably a little bit of blood, it's probably a little bit of, well, everything else. So a lot of times this can be a pneumonia patient. Or purulent is kind of like that kind of yellowy pus looking color. So here's a registry question that they love to ask, and actually you'll probably see this on FISDAP. If you have a 40-something-year-old male, and I don't know the ages, I'm just throwing it out there, but if you have a 40-something-year-old male with pink frothy sputum, what is that? What is that most likely? So frothy, usually pink tinged, and a lot of times what that that can come from a couple different things. So pink foam or froth is usually a sign that air was physically forced through pulmonary edema, and so a lot of times this is the congestive heart failure patient, where there's just a general failure going on in the heart. Again, they probably have that thicker blood. That thicker blood has to forcefully be forced through that capillary bed. So a lot of times it pulls a little bit of blood with it from that capillary bed, and that ends up making it into the alveoli, which makes it out into the lungs. And when they cough stuff up, they get that blood tinged or that pink, that frothy kind of sputum. So again, that frothy sputum is usually associated with congestive heart failure. So if I tell you that you got this 46-year-old patient, trouble breathing and history of, trouble breathing with pink frothy sputum, you most likely think the diagnosis would be what? And the answer would be heart failure. Now, if I told you that it was a pink frothy sputum with a fever, that is no longer heart failure. Heart failure patients do not have a fever. A fever is an infection. An infection is an acute thing. So what we know now is that this pink frothy sputum just simply means that there was forceful, there was forceful red blood cells that physically got forced through the capillary bed into that alveoli, and it took some of that pink blood with it. But again, if they have a fever, that can happen with pneumonia. So again, your body's still trying to breathe really, really, really hard, really forcefully. There's times where that air is physically forced through that pulmonary edema, but instead of it being pulmonary edema fluid, it's being forced through infection. So there's pneumonia down there. So it's physically trying to force that air through this infection and out into the lungs to be able to be exchanged. So my point here is, if the patient has a fever and pink frothy sputum, it's not congestive heart failure, it's pneumonia. If the patient has pink frothy sputum and they don't say anything about a fever, then it's heart failure. But at the end, the take home for this is pink frothy sputum just simply means that air was forcefully pushed through that alveoli and through that capillary system. But they love to ask that question, because in your book, pink frothy sputum is 9 times out of 10, 100% associated with that heart failure. And again, that's not the case if they have a fever. And then blood tinged sputum. So that's worth writing down also. So blood tinged or blood, any kind of blood tinged that isn't like frothy. So frothy, basically, again, we're talking about that forceful airflow. So it's going to be bubbly. It's going to be thick. It's you've literally forced air through something. So it's going to foam up. That's what the frothiness is. If it's literally just they're coughing out streaks of blood, like big, thick streaks of blood, that's usually either some type of tumor or some type of tuberculosis or something god awful that, specifically tuberculosis, that we definitely want to have some kind of precautions standing by. So again, notice the difference between the blood streaked and the frothy. Those come from two different things. And again, the diagnosis is very, very different. Mm-hmm. So blood streaked is going to be probably tuberculosis on a test. Frothy anything is probably going to be heart failure unless the patient has a fever. Hopefully all that makes sense. But those are like 3 test questions kind of all together right there. Please ask if it doesn't make sense. Hearing no objections, we'll move on. Um, Breathing, we talked about this. Neurological problems, so brain issues, spinal cord problems. The brain doesn't have the ability to send normal signals anymore, so all this other goofy stuff happens. The big ones to remember: Shane Stokes. Shane Stokes is a ventilatory pattern that's consistent with a head injury. Biot's. This is, or Biot's. This is essentially the V-fib of breathing. So it's pretty much all over the place. There's no rhyme or reason for any of it. So that's essentially the V-fib, or ventricular fibrillation of breathing. And then the big one to remember is, the other big one is the Kussmaul's. And Kussmaul's is very, very specific to, usually to the overaccumulation of carbon dioxide in the body. And that's the regular deep ventilatory pattern here. And again, the big one for that is Kussmaul's is usually associated with diabetes. So there's a problem with the cord, which equals problem with the breathing. They need to be assisted. With the skin, this kind of lumps in some pediatric stuff with it also. We know that those feet don't look too bad to me, but again, there is some cyanosis to that. There's some blue. It's a little bit discolored, but again, I don't think that's a problem per se to me. We're looking for general cyanosis. So again, some people are generally cyanotic. They're generally just blue. There's a couple of disease processes where they want to be just blue. They want to be left alone at 86%. And they'll tell you that. Some of these COPD patients, you'll never get them to 100% because they physically don't have the lung capacity to do that. So getting them to whatever their normal is really all we need to try to do. Some of the different skin colors, again, they're trying to prove the point that there's a lot of relationship between the circulatory system and the lungs, and I think we know that. I don't care if you don't memorize the hemoglobin levels in a person. I don't care about really any of that, unless you're super interested in that kind of stuff. But we're not going to be able to check that. So really, pale and cyanotic. Those are the two things that I'm truly concerned about. Cyanosis is obviously a hypoxia. And pale is basically some type of blood flow restriction or shock. So we're looking for dehydration if they're dry or cracked or sunken in eyes or sunken fontanelles, which is the little soft spot, obviously, on a baby's head. If any of that is kind of sunken in, we know that there's a circulatory problem. Again, those patients need fluid. But if it's a ventilatory patient, so if they're breathing, if they got a COPD or whatever, and they have all of this going on, they probably need fluid and a breathing treatment to try to rehydrate them. Transport decision, if it's an airway problem, we try to go to the closest hospital. Registry will ask a ton of these questions. Would you rather go to the nearest trauma center that's 40 minutes away, or the closest community hospital that's 15 minutes away? That 100% has to do with the stability of the patient under your care. So if you're managing the airway appropriately, go to the right hospital. If it's a trauma patient and you think they're bleeding out, the community hospital's going to let them bleed out because that's not the definitive care. If it's a respiratory patient and you don't have an airway because you can't get a good airway for whatever reason, then you go to the closest hospital. So again, go to the most appropriate facility if you physically can. But if there's anything in the question or anything in your head or anything in real life that tells you that if this patient is not going to make it to that hospital, then we should go to the closest facility. So anybody that's profoundly again, airway problems or anaphylaxis that you can't correct or you can't handle or you can't manage, they go to the closest hospital. History taken, they're going to tell us what's going on in their own words or their chief complaints. Do you cough a lot? Are you spitting up a bunch of stuff? Again, do you have a fever? All the basic stuff. Do you have chest pain? If they have chest pain, you'll probably want to do it. You'll add a 12 lead to your treatment. There's nothing wrong with adding a 12 lead to your treatment on all of this, because now we know congestive heart failure. We know that that's the heart's working extra hard. So there could be some hypoxia going on also. So there could also be a heart attack that leads to this. The heart's not pumping well enough, working up into the lungs, and now the patient's manifesting with lung problems when the original culprit was the heart. So these are gonna work hand in hand. So we're gonna do a 12 lead. We're gonna start an IV on these patients. We're gonna give them fluid just to try to get their blood pressure at least manageable. If they have wet lung sounds, we're not going to give them too much fluid because, again, all we're doing is we're going to compound the problem. A lot of times they know what's going on. They've dealt with this before. They know that they have asthma. The asthma with a fever is kind of a goofy thing for them to write in here. But really, with a fever, your body is going to breathe a little bit quicker because there's an infection. Where there's an infection, there's a buildup of that lactic acid or acid. So the body knows that it needs to breathe faster to get rid of that acid. So with the infection of a fever and breathing quicker, that will flare up somebody's asthma pretty quickly, and they'll know that. So they failed to take their medicine. They just got off an airplane, and the pressure differences have messed with them somehow. They'll be able to tell you exactly what's going on if you ask them. Get a sample history. With the sample history, so signs and symptoms, we want to know about the respiratory difficulty. If they're a CHF patient or if they're a chronic bronchitis patient, I want to know how many pillows they sleep with. If they sleep with 14 pillows and they're sitting straight up in a recliner, that tells me a lot right there. If they're a CHF patient and they sleep flat on their back, then there's not enough fluid accumulating in the lungs to really affect them or give them that nocturnal dyspnea. So maybe that's not a big deal. Maybe this is early stages and I don't have to be as aggressive in my treatment. So signs and symptoms it's pretty important to start asking questions that relate to your differential diagnosis. What do you think is going on? And this is what we use to confirm that. So we're not going to be too quick to just judge and say, hey, this is absolutely a respiratory problem. Because again, we know that this could be a heart problem manifesting with respiratory symptoms. So allergies, we know asthma can be triggered. So are you allergic to environmental stuff, pollen, and whatever? Do you feel like this is more of an asthma thing? And that can lead us down that road. With the medications, are you on an inhaler? Do you take a steroid on a regular basis? Do you take Claritin every day? That tells us that they have allergies, where they have allergies, then I can kind of with a little bit of reasoning, I can say, well, this is probably an asthma attack. Listen to lungs, you'll probably hear wheezes, and down the road you go. As far as the past medical history, does anything make it better or worse? It's the basic questions that we're going to ask. What happened the last time? Statistically speaking, if a patient looks at you and says, "Hey, I had an asthma attack," well, what happened? Did it take care of itself? And they say, no, I went to the hospital. Well, what happened at the hospital? Well, I was intubated. If a patient was intubated because of asthma before, there's a really, really high likelihood that this time they're going to need to be intubated again. So that 100% should trigger something in your brain that this is a sick patient. We need to get rolling. We need to get to the hospital. I need to have all my intubation stuff set up in case they lose consciousness or something like that, and I need to intubate them. So this is the fact that they've been intubated before is a pretty big deal. We'll check their level of consciousness, their ability to maintain their own airway. Moving down from there, we look into the neck. These jugular veins that we always talk about. This is a good one. This is a good obvious one. But a lot of times when we're looking at these patients, they're either semi-Fowler, so they're like a 45-degree angle or less. If you're trying to assess neck veins on a patient and you try to lay them flat, again, we're going to probably exacerbate the other problem. And the problem is they need to sit up because they're having a hard time breathing. So if you lay them down, that fluid covers the back of the lungs. And again, you've lost half your lung capacity. So you got to kind of be careful with that. But these neck veins, sometimes you'll see them pretty commonly in asthma and COPD patients. Again, there's a high intrathoracic pressure all the time because they're trying to keep those lungs open. So with that high intrathoracic pressure, it stops the ability of these jugular veins from dumping back into the vena cava and back into the heart because, again, there's the pressure is too great on the inside of the thoracic cavity. So sometimes you'll see that. It can also be caused by some traumatic issues, some heart failure, again, COPD, and some things like that. But a lot of times it has to do with the pressure on the inside. And this is kind of a demonstration, I guess, somewhat of that. You can see all of the vessels are all compressed in here. This happens to be a tension pneumothorax, which so a pneumothorax just means that there's air in the thorax. Very, very simply put. This can happen spontaneously, and we'll talk about this too in just a few, but the lung can spontaneously collapse for a couple different reasons. And if you collapse a lung, then obviously there's some type of hole that has deflated it. That hole that you can see in this picture here, when the patient takes a breath, air is going to come in. It's going to go into this through this hole and into this pleural cavity, and pressure is going to start to accumulate in this pleural cavity. This particular picture is a gunshot wound, so you can see that air comes in here. Somehow the bullet went through here and through the actual lung tissue when it was inflated out here. So again, the breath comes in, and if you just follow the track, breath comes in, goes into the lung, out the lung, and into this pleural cavity. And what ends up happening is all the tissue from the gunshot that shot inward, all the tissue has kind of flopped inward. And when that pressure starts to accumulate, that will kind of self-occlude itself. And that's a really hard thing to kind of understand, but this will start to clot off because there's going to be blood and secretions and all kinds of other goop and stuff that's hanging out there, in addition to the tissue that was blown open by that bullet. So that pressure starts to build, and as that pressure builds, it kind of occludes that. So air cannot escape now. So this creates a problem. Every time they breathe in, air is starting to build into this outside lung cavity. It starts to compress the lung. The lung doesn't particularly matter with this particular lung, but what this patient's doing is they're filling this entire lung border. So as this starts to fill, you can see where all the vessels have started to kind of change. They've started to kind of move, and it's starting to kind of compress to the other side. So again, these patients, this becomes a very, very critical patient. These are the patients where we have to needle decompress them. So the second or third intercostal space, so like these ribs that are up in here, we'll take a 14 or 16 gauge needle and we'll physically poke into this area and create a hole for this air to evacuate itself. So again, a pneumothorax by itself is not a problem. It's something that can be surgically fixed. A tension pneumothorax is where there's so much tension in here that is physically pushing on these vessels, and it's creating some type of hemodynamic problem. So now they can't physically breathe. They're having a hard time breathing. They're having some circulatory problems because the major vessels are starting to become cramped off. Their blood pressures are starting to change and be affected. So these patients, these are definitely fatal right here. So once a regular pneumothorax becomes a tension pneumothorax, that has to be treated by us. So you won't hear any lung sounds on this side at all. So that could be a test question. So if you listen over somebody's lung after a gunshot wound and you hear no sounds over the right side, this is exactly what you're dealing with. You're dealing with a tension pneumothorax. There'll be altered mental status, or their blood pressure will be in the toilet, or they'll be, their pulse might be 180, something really, really fast because they're trying to compensate for all this. So the treatment of this is this needle decompression, and we'll talk about that here in a minute. Some other things that we're looking at: chest and abdomen. If there's too much pressure in there, again, too much airflow, we know that's going to be a problem. We know that pressure can also dislodge the return rate. So we can have some jugular veins that become backed up and somewhat engorged. We'll get through the secondary assessment, and we'll take another quick break. We're going to look at the extremities, and nothing really specific here other than there's that pulsus paradoxus again, where you can feel a better pulse on the exhale when that interthoracic pressure starts to decrease. We're looking for edema. If you look at this ankle, looks like somebody pushed a finger into the ankle and it stayed there. That's that edema. That's just fluid that you physically pushed down and displaced, and your finger stays there like Play-Doh. Clubbing is this big squared off finger. A lot of times that has to do with chronic hypoxia. Again, it affects mainly capillary beds, and the capillary beds end up pretty much engorged and not really able to do a whole lot because, again, the blood is thick, and we go back down that whole COPD problem where it's pretty traumatic just to have that. That fluid shift through it with thick blood. Vital signs we're going to look for, obviously, the bradycardia, tachycardia for that matter. The big thing that I care about for this is for these patients is hypotension, because again, as long as everything's being perfused So they have a somewhat normal blood pressure. I'm not too super concerned about it. But if these patients start to fall into like the 80/60 world, or anything for that matter, anything under 90 for these medical patients, I'm a little bit concerned about. Even anywhere under 100 even. The book's going to have some varying answers on that as we move through, but test questions will all be very, very specific. So it'll be 60/40, or the blood pressure will be 220/110. Like the high is going to be high and low is going to be low. It's not going to be right there on the border. We're going to listen for lung sounds. We're going to put a pulse ox on them. This is not useful at all. So normal tidal volume. So the normal tidal volume in a patient is between, in an adult patient, we can expect 350 to 700 liters. So 500 is right about the average. Bag valves, depending on the manufacturer, some bag valves are usually somewhere in the 700 to 1,000 range, depending on the actual model or the actual manufacturer. So what that tells us right away is that there is more air by a lot inside the traditional bag valve mask than what the lungs can physically hold. If the lungs can only hold 500, that's why instead of physically squeezing a bag just until you can physically squeeze it, we're going to squeeze it just until we see chest movement. So once the lungs inflate enough that it physically starts to move the chest, you stop inflating because it's full. All you're doing is hyperinflating, and that can create a pneumo, because you can ultimately collapse a lung by putting too much air into it. And we know that a collapsed lung while we're ventilating, all that does is continue to compound until now it's a tension pneumothorax. Now you got to treat it with a needle. So something as simple as how much air you're breathing into people is critical for us to get that right. So again, we're just squeezing enough to get air, just the chest rise. That's really all we're looking for. And not that we're going to be able to necessarily quantify it, but less than 150 liters per minute is inadequate. So again, these are the panting patients. They're just panting. They're not breathing. They're not breathing effectively. And if they're not breathing effectively, then we have to make them breathe effectively. So that's going to be either an adjunct or some kind of assisted ventilations with a bag valve mask. And then we're pretty much going to reassess everything. So any questions on that? I know this is a lot of information, but hopefully you're not hearing this stuff for the first time. Is there any questions on that so far? Everybody's mind's mush. Hopefully it's not too bad. This shouldn't be too far removed from EMT, just with a couple mild exceptions. So we still have a bit to go. Take about 5 if you can, and we'll get back at it. Systems. Sorry, a lot of the reasoning behind what we do. Again, that is pretty much my forte with a lot of this stuff. So again, feel free to ask questions if things don't make sense. I really want you to know, again, not just what to do, but why we do what we do, because that truly will make a difference in you as a clinician, knowing some of the off-label uses of some of the things that we do. Being able to, if you know why we're doing something, then you'll understand what happens if this doesn't work, which allows us to have a plan B already set up in mind. So all of this stuff is a really, really important thing for us to start to kind of bring together. By the end of today, I'm hopeful that you guys at least have a good understanding, at least a foundation of how to treat a respiratory patient, how to treat an airway problem. If you can identify it, if you can figure out why the problem exists, and you can figure out how to treat it, again, that's going to be a majority of the run volume that we have. The next would be probably cardiac, chest pain problems. That's kind of Pandora's box, because there's a whole bunch of different weird stuff that happens with the heart. And again, that's almost the entire term, next term, which, by the way, next term is like 3 class days away. So we're almost done with term 1. So we're almost at the 25% point of medic school. So that's pretty awesome to think about. So as you get into this, again, airway, you got to be a master of airway. And it's not going to happen overnight, and it's probably not going to happen by the end of this term, but the foundation needs to be there. That way you can go out and start to identify this stuff in the field. So here's our treatment of it. So our goal is pretty much to do everything supportive. And that is treating this patient as an EMT basic first. We know that oxygen is probably what an airway patient needs. By definition, they have some kind of obstruction that's preventing oxygen from making it to the body. a layer deeper than that in the medic world is we know that oxygen is not getting in. In some cases, carbon dioxide is not getting out. So we need to be able to treat that also. So again, you're going to look at your patient. You're going to figure out if they're what their problem is. You're 9 times out of 10 going to realize that they probably need oxygen. And we just have to figure out which method is the best way to get that oxygen in there. Do we need to open them up first so that the oxygen can go where it needs to go? Do we need to get the oxygen in a little bit quicker because they're not doing it themselves? Do we need to slow down the oxygen delivery? So are they breathing 38 times a minute and being non-effective? So we have to determine how do we get that oxygen level at that 100% or close to it or whatever normal is for them, and we got to just figure out kind of how we're going to do that. So we want to try to get them over 94. That is going to be a textbook. Anything 94% or lower is going to be hypoxic by definition. And then the subjective side of that is, well, what is severe? What is mild? And really, it doesn't matter. Just under 95. So 94 and below is bad. 95 and above is okay. So we're going to do oxygen IV. We're going to probably add a 12 lead to this, and we're going to be all socially supportive and psychologically supportive. To the best of our ability anyway. Sometimes we just physically can't do it. Sometimes we can. We just got to do our best to do that kind of stuff. So IVO2 monitor is going to be the 3 things that you're going to say to pretty much every patient that you have from here on out. So IVO2 monitor, which is a 12 lead. So you're going to do those 3 things for just about every patient that you encounter. As it relates to medic school, you'll be safe to do that on all of our patients. Pretty much all of our patients are going to need IV O2 monitor, with a couple exceptions in the oxygen. And that's what I kind of want to talk about. If they're at 95%, they really don't necessarily need oxygen. They certainly don't need high flow oxygen. There's some exceptions to that, and we'll talk about that here in a little bit. But so we've responded. We're going to assess their work of breathing. We decide if they need ventilation or oxygen or both. We're going to try to get them to sit up, try to take off any kind of constricting clothing that they have. Again, try not to make the patient walk. If the patient lives 3 stories up, they're fat, they're out of shape, and they're having trouble breathing, try your best to fight every urge in your body to tell them to walk their ass downstairs. Try not to do that. Get a stair chair. You're a medic now, so as a medic now, you've got basics. You got firemen to do that job. So tell the fire people to ambulate this person down these steps and into my office, and use that. I have no problem doing that. I got to do this thing over here and watch their breathing and stuff. I'm going to be the doctor over here. You guys do the lifting and the moving and that stuff. I have no problem doing that, especially if you're the primary care provider. Last thing you need to do is get behind the patient where you can't actually assess them if something happens going down. So we're going to give them some oxygen. So this is where there is an amount that's appropriate. If so, any kind of concentration higher than 50% should be used pretty much for patients that are hypoxic, right? That's a pretty generalized statement. So if they're hypoxic, if they're really, really low, so if they're in the 80s, then we need to give them higher than 50% to try to bring them back up. So basically what we're trying to determine here is whether or not you want to give a nasal cannula or a non-rebreather mask. Anytime you need to use the word high flow oxygen, so high flow oxygen would be a patient that's having obvious trouble. Obviously they're having difficulty breathing. Anytime they move, they become short of breath. You can tell the patients that are just profoundly hypoxic. Those patients, they need 100% oxygen via non-rebreather mask. Like 12 to 15 liters per minute. And that's what I'm going to say to any patient in any scenario that needs high flow oxygen. High flow oxygen, non-rebreather mask, 12 to 15 liters per minute. That is what high flow is. Anybody that's in the low 90s, and again, this is just kind of arbitrary, but arbitrarily, anybody that doesn't need that high flow or that high concentration, I can give them the nasal cannula, which is less than 50% concentration. I can give them that at somewhere 4 to 6 liters per minute, somewhere in there, and that's low flow oxygen. So again, it's how profoundly hypoxic are they, and how much work of breathing are they actually exhibiting, and that's going to give me the answer between the two. They do ask some questions in testing about that. So basically, the idea is the use of 100% oxygen. So a non-rebreather mask, 100% oxygen, that should be used for the shortest period possible. So if I can get that patient up to 98% or 99%, and then titrate that down and back them down to a nasal cannula, that's not what we do in the field, but technically that's the most appropriate way to handle this. We don't want to give people 100% oxygen because eventually your body is going to start to say, oh, well, I don't need to work as hard because I've got it coming to me automatically. So we don't necessarily want to train the body to do that. So 100% oxygen should be the shortest period of time possible. And then we should try to back it down. People with good oxygenation saturation, so at least 94%, over 94%, statistically, they don't benefit from supplemental oxygen. Now, there's a caveat to that. So we still have a standard practice where any patient that has trauma, so if they're bleeding on the floor, their hemoglobin, which carries their oxygen, is over there on the floor. It's not in the body. So whatever's left in the body, I want to make sure is good and saturated with oxygen. So I will give 100% high flow oxygen to a trauma patient because again, I need to make sure that whatever oxygen, whatever hemoglobin they have in there is filled with oxygen. So I'll give them the benefit of the doubt and they'll get the high flow oxygen. And I guess not even high flow per se, just oxygen period. A stroke patient, there's some kind of occlusion somewhere in a stroke patient. So a stroke patient is going to get oxygen from me 100% of the time because again, whatever's being blocked, whatever collateral circulation, I want to make sure everything has good oxygen amounts. Any kind of heart attack's the same way as a stroke. There's a blockage, but the blockage is in the heart. So I'm going to try to give them, they're going to get oxygen from me. But basically, my goal is not to hyperoxygenate them. My goal is not to find 100%, although that'd be perfect in a perfect world. But once they get over that 94% hump, there is no reason that we can't back them down. If you work with me, or people that think kind of like I do, capnography goes on just about every one of these patients. I can't think of an example why I don't even use capnography anymore on anybody. But the capnography is the non-rebreather, or I'm sorry, it's the nasal cannula that goes over, and then I'll put that on, and then I'll put a non-rebreather mask over them. So for me to transition from high flow to low flow is as simple as me just taking the mask off of them, and then just turning up the low flow, turning up the capnography delivery or the nasal cannula delivery. I think that was all I wanted to talk. And then of course, local protocol dictates some other stuff based on this, but that's not super valuable for us right now. So bronchodilators. So again, we know we got to give oxygen. So who can benefit from bronchodilators? Well, anybody that has any kind of tightness for any reason. So we need to dilate that. So pneumonia, there's an infection down there. We need to dilate everything around that infection to try to give the patient the most surface area of alveoli as possible. Pulmonary edema, the same way. I need to open up that the bronchial tracheobronchial. Yeah, say that 3 times. I got to open that up because if I don't open that up, the surface area is not going to be there for them. So I'm going to open that up, and by opening that up, one side effect, positive side effect to this pulmonary edema, when I open them up, that opening gives this pulmonary edema a place to go. So as I open up that bronchial tree, it ends up creating this interstitial space down in between all the alveoli that pulmonary edema, that fluid can kind of settle into. So as it settles in, I've actually opened up the actual bronchial tree, but I've also opened up the surface area that oxygen can actually make it to that alveoli. And of course, heart disease patients. But again, this is going to be the cause of something more respiratory related, which is why the bronchodilator is going to work for the heart disease patients. Now, it says that these are ineffective. Now, I was waiting for somebody to say something. The problem with it being ineffective is this is not it's not a permanent treatment. These patients are still going to need antibiotics. They're still going to need some type of diuretic to get rid of this. And of course, heart disease, like I said, it's not necessarily going to be the heart disease that's the problem. It's going to be the lung that's the problem. So my point is, when you're looking at this, it says very specifically that these are ineffective in cases of this, and this, and this. When you're listening to the patient, if the patient has wheezes, If the patient is short of breath and the patient could benefit from dilation, then you do it. And there's nothing that says you can't do it. It's just saying that these are generally ineffective. Now, again, a lot of this is protocol driven, but in full disclosure, it will absolutely work for these three. But again, it works differently than what the book is trying to tell you here. Hopefully that makes sense and doesn't confuse anybody. So fast acting, that's exactly what we carry. We carry the albuterol. It stimulates the beta 2 receptors in the lungs, which basically causes almost instant relief. And it doesn't take really any time at all. It happens pretty much on contact. We used to give, I don't even want to talk about, we used to give aerosolized like atropine or something else. And we're going to put that out of our brain for now. But ipratropium bromide is the Atrovent. A lot of times we're using that as roughly a first dose mixed with the albuterol. That's called Duaneb. So a lot of times we'll use Duaneb. They act a little bit differently on the body, but basically those are usually pre-mixed and they work very, very well. There's some other ones that the book likes to talk about, but Duaneb is really the one locally here that we're going to see most. So aerosolized therapy, again, we put together the handheld neb. 6 liters per minute is the minimum for the particulates to actually nebulize. I guess it's kind of important to think a lot of people at home have a nebulizer system at home with a small little air compressor. Those patients are usually getting like 30 to 40% oxygen out of those small those basically one treatment is only 30 to 40% oxygen. To compare that, depending on what they're on normally at home, again, if they're on 2 liters per minute, 3,000 feet of tubing that runs under the dog in the kitchen counter, they might not be getting really anything. So 30 to 40% oxygen through this treatment might not be a bad thing. But for us, we usually go straight to the 6 liters per minute, and the families will probably complain. I have had quite a few complaints, like, they're on 4 liters per minute, and I'll turn this to 6, and somebody will actually try to micromanage that and say, well, no, they're not supposed to get 6, or they're on 4. It's like, cool, sit down. We got it. We'll work through it. And again, in our short term with these patients, over oxygenating them or hyperoxygenating, it's not the end of the world. As far as this is concerned, when you're nebulizing something, nobody cares. 6 liters per minute or greater, that has to happen, or else this isn't going to work anyway. It can be attached to a face mask. Hopefully everybody has seen that done, where you pull the bag off the bottom of the non-rebreather mask and stuff in the actual nebulizer chamber. That fits right in. Obviously we know that we can no longer deliver 100% oxygen if the bag's not attached. We're literally only giving them the 6 liters per minute of 30 to 40% oxygen. But we can absolutely do that. Nebulizers can be blow-by, so kids aren't going to be able to suck on the pipe that we normally do. And they may or may not tolerate a face mask. So if that face mask can physically blow that aerosolized medication by their face and they breathe it in, that's fine too. We know that we can, some of the other things that we don't necessarily use, some solumedrols or prednisones can be dispersed through this. That's a very, very specific brand though of corticosteroid. So again, we're not going to do that in the field. Anesthetic, so breathe this in, you'll fall asleep. Cough suppressants and the mucolytic, so basically the Mucinex or something like that can be aerosolized. A lot of times that's going to be something that physicians are going to do and not necessarily something that we're going to do. All right. So big picture, we showed up, patients having trouble breathing. You get a good sample history. You've identified that they have asthma. This feels just like asthma. They've hit their own inhaler a couple times. It didn't work. What do? Well, they're wheezing. So if they're wheezing, they need a bronchodilator. So we got to open them up so that we can get the oxygen in. So we hook them up to our nebulizer. We give them our albuterol, not theirs. I pretty much always assume that theirs is either outdated, not given appropriately, or something like that. Technically, they should count into your maximum of 3 doses. That's an easy phone call to say, hey, they've given themselves 14 puffs of this expired med. It's not working. Can I get my own? And there's never going to be a question with that. Most protocols will still allow it as a standing order. You don't even have to call. I'm just going to assume that it's outdated or they gave it to themselves wrong. So again, they're wheezing. I preferably would like to set them up with a nebulizer in the squad and let them go to work on it. With COVID, with coronavirus being a thing right now, aerosolized medications are still frowned upon. So because of that, a lot of times trying to give them an inhaler, or I'm sorry, a handheld nebulizer, it's going to disperse all their exhaled air all throughout the ambulance. So ideally, if they have a bronchodilator, I just have to I got to break my own rule, and I'm going to try to use theirs instead of mine. And as a medic, that's okay, as long as it's the right dose, the right patient, the right route, the right, all of the rights are there, and it's their prescribed inhaler. There's nothing wrong with that, as long as it's not expired. So I'll shake it up real good and I'll give it to them. If you're not familiar with this is a chamber. A lot of times what these chambers are for, you can spray this. So basically the whole idea of an MDI is exhale as far as you can, spray it at the very start of your next inhale. You spray it and actually deliver it then. What this chamber does is it allows you can spray it into the chamber. The particles will hang out in here until you just breathe normally, and you breathe it in through 2 or 3 breaths instead of one giant breath. Works great for kids because kids can't on command do anything. So specifically, they can't breathe a deep breath when you ask. They'll get sidetracked or distracted or something. So a lot of times they'll use these chambers for that, or spacers. That's pretty much what we just talked about. Sometimes they can fail, and if they fail, you use our own. Dry powders. This is like an Advair. There's like a little purple hockey puck looking thing. And inside there's a little pouch. And inside the pouch is a powder. So basically they press down, that punctures the powder, and it punctures the little disc, releases the powder, and they physically breathe that in. Again, this is more of a chronic day-to-day thing. We don't use this in the field, and they don't even really use this in the hospital, in the ER setting anyway. Moving forward, this top one is just like Singulair. Singulair is a daily medication. This leukotriene modifier. Patients will take this every single night, and basically it keeps the bronchial tree somewhat open, and it does it by blocking the things that would generally constrict. So a lot of times this is like your seasonal allergy patients, where every day there's some kind of bronchoconstriction. So they'll take one of those that will modify that particular beta 2 site, and they take that on a regular basis, and that kind of keeps them down without that constriction. Electrolytes, magnesium. So I know Fairfield Township for a while had a weird protocol, and I can't remember the other places locally that did, where a severe COPD patient or asthma patient, once you get down into where you would give solumedrol, you would also give magnesium. Magnesium, and we'll learn this later unless you did your drug cards, it's a smooth muscle relaxant. So if I can relax the smooth muscle, that would also relax the smooth muscle that makes up my trachea and some of the larger bronchioles. So there is some research to suggest that the magnesium administration, which is an IV med, that there can be some benefit to relaxing that smooth muscle tissue. So steroids, we know that it reduces edema. It takes forever to onset. They'll go home with this. One key thing to if you're writing stuff down for corticosteroids. So again, I'm talking about prednisone or solumedrol. Both of them, when you give them, have the ability to alter blood glucose levels. And it's super complicated how it works. This is more of a memorization thing, but it basically tells the liver to stop accepting insulin, or it basically tells the body to stop accepting insulin. So you end up with a pretty rapid change in the glucose, and it's while you physically have the patients. And again, it's just it physically affects the body's insulin resistance. So just know that anytime you give any kind of steroid, there can be a change in blood glucose levels. Let's skip through some of this because we already talked about it. So vasodilators. So again, we're still down the treatment path. So we've already given we're trying to get the oxygen in. We've given the beta 2 agonist. So we've tried the albuterol. We've considered the solumedrol. We've considered the magnesium in the rare cases that actually is used and works. Now we're getting more critical here. So now we're getting down into the vasodilation system. So if a patient has a vasodilator, the big one that comes to mind for us is nitro. So nitroglycerin, it dilates all the blood vessels, all the coronary blood vessels around the heart, and allows us to kind of have this collateral circulation where we can let blood sneak by these clots because we've dilated everything so big. Obviously, when you dilate everything, there's the vessels are a lot bigger, which means the pump has to work a lot harder to maintain the same pressure. So we usually see a decrease in blood pressure when we give nitrates. That's going to be a huge thing with nitro. The reason that we would do this, though, is we would dilate. We would basically dilate everything in the system. And again, we're referring more specifically to the trouble breathing patient. It is because everything's dilated. Everything, the fluid has to physically go somewhere. It's going to fill up in that. It's going to fill up in the actual vessels. It's going to lower the blood pressure. Again, we got all that part. But what it typically will end up doing is it'll end up creating all the fluid that accumulates in the lungs. It'll give that a place to go. So we dilate the vessels, which allows more of the fluid from the lungs to settle into the vascular system, where otherwise the pressure, it would have taken more pressure than it has to get back out of the lungs. So basically, we're going to use a vasodilator to pull fluid out of the lungs and back into the bloodstream or into that interstitial space. So this is that CHF patient. So you've got the congestive heart failure patient. Left side of the heart backs up into the lungs. The lungs are filled with fluid. You're trying to do everything you can. So you'll put a CPAP on the patient. You'll try to push everything out. You'll probably give them a diuretic, like a Lasix, to try to get some of that extra fluid to be urinated out. And as kind of a last ditch effort, you can give some nitrates. You can give that 0.4 milligrams of nitro to this patient, and it vasodilates and allows that blood or that fluid to kind of come out of the lungs and back into the actual ventilatory, or the circulatory system. We're going to give some fluids, but not too much. Obviously, too much fluids can create some problems with the pulmonary edema. It can add insult to injury. As a test question, a fluid bolus. So you've started your IV, you've hung your fluid bag, and you've hung your normal saline. You flushed everything out. How much is a fluid bolus? The textbook answer is going to be 20 milliliters per kilogram. 20 milliliters per kilogram for an adult. So I say that because I've tutored a couple of students in the other class that are having some trouble with trauma. The fluid bolus for a trauma patient is the same as a fluid bolus for a medical patient. It's still 20 milliliters per kilogram. So you figure out their kilograms, and you do the basic medical math. For every 1 kilogram, they get 20 milliliters per kilogram. Once you get down into neonates, it drops down to like 10 milliliters, but that's like brand new newborns. Kids on up through adults, it's 20. That is the textbook definition for a fluid bolus. So we're going to assess breath sounds before and after that, because we want to make sure that we didn't give them too much fluid. We're going to think about a diuretic. Again, we're going to reduce the blood pressure. We're going to try to get them to pee off some of that extra fluid. We know that the diuretics can cause all kinds of loss, not just potassium, but also sodium, because again, that's what's floating around in the fluids that we're losing. Anytime you start messing with sodium and potassium in the body, we end up with heart problems, because sodium and potassium, those are the two electrolytes that physically make the heart beat. So those two being peed away, that can create some arrhythmias. We're going to assist ventilations if need be. So again, the patients that need aggressive support, that are still physically breathing, CPAP is a great thing. That can happen before or in place of intubation, as long as they're physically breathing. And by intubation, they mean RSI and intubation, because again, this is a breathing patient. So if they just need assistance. So why would I do CPAP? Well, if I listen to lung sounds and I hear nothing but fluid in there, and they're clearly having a hard time breathing, that CPAP is going to force air in. It's going to force the, let me skip ahead here. It's going to force the diaphragm to contract or to move, and it's going to increase the intrathoracic pressure. And they use one of them cool fire fans. Again, pictures are, these were not my choice, but I digress. So again, CPAP, any patient that we need to open up that airway. And again, a lot of times these small, the lungs, they're already filled with carbon dioxide. They're not ventilating very well. There's a lot of fluid in what's left, and these patients just aren't breathing. They're not breathing very well at all. So we're gonna take that forced air, we're gonna shove it down in there on a continuous level, and we're gonna let that go. So, and hopefully our goal is that fluid that's accumulated in that pulmonary edema is going to start pushing out into that interstitial space, and it'll help keep open the alveoli that we need. So sometimes they use it for sleep apnea. A lot of times, well, that's the normal treatment for sleep apnea. You have a CPAP that you take around with you. Obviously, patients that are not breathing can't do this. They have to physically be ventilating on their own. But basically, we force air in, and we keep that airway positively pressured, as much oxygen as they're going to need. Sometimes, so we end up needing to regulate the actual ventilation. So CPAP, going back to CPAP, if they're breathing 38 times a minute, CPAP's not necessarily going to fix that. All it's going to do is pressurize the system. So if they're breathing 6 times a minute, again, CPAP's not going to assist that. It's just physically going to pressurize the system. So bag valve is if their ventilatory rate is either too fast or too slow or not adequate enough. So sometimes we have to physically support that, and we have to take over. Obviously, if we do too much pressure, we can cause a pneumothorax. And if we cause a pneumothorax, we don't notice it, and it becomes a tension pneumothorax, then that creates a whole nother surgical procedure that we have to perform. So again, be cautious with that. Subcutaneous air is basically if there's any kind of perforation in any of the bronchial tree and air starts to seep out into the actual tissue, that's subcutaneous air. When you push on that, specifically like a cricothyroid, so if you do any kind of cric, air can seep out into this interstitial space, and when you push, it actually feels around the skin. It feels like popping Rice Krispie treats, because there's trapped air underneath there. And too much pressure blocks the venous return, which is the same reason you'll see that jugular vein distension. So a lot of times what we're going to do, this is CPAP very specifically, which is, this is not obviously bag mask. But nonetheless, we create the seal. My goal would be to try to sneak in some type of capnography, so I can measure and make sure what I'm doing is actually appropriate. The systems, the CPAPs usually have some type of pressure relief valve. So if the lungs, if they know, it'll end up, they're designed to hit a certain pressure. Once that PSI is met, all the additional pressure would be actually sent out and diverted away from the patient. That way the CPAP itself doesn't overpressurize the lungs and create that pneumothorax. I'm moving through some of this stuff. BiPAP is basically a demand. So when I take a deep breath in, it assists that. And when I stop taking the deep breath in, it pauses. This is a 1928 model automated transport ventilator. Some departments still carry these, but basically you just set this on the patient. You set your actual flow, how much volume you physically want to give. So here's tidal volume down here in this bottom left knob. So you set that somewhere around, so remember 700 was the max for the normal adult. So I'd set somewhere in there, and then you can set your rate, and you physically set your rate, you turn it on, and you walk away. Every so often, according to your rate, it'll deliver the actual ventilation. Again, there's good and bad. Some of the bad is specifically that you can't always tell if there's a problem. A lot of the newer ones are digital, and if there's an increased interthoracic pressure, it will notice that. It'll notice that the ventilations need to be a little bit more forceful, and it'll either alert or stop, or some of the brand new ones will physically alter the actual flow pressure to not create a problem there. So if all else fails, we intubate them. That's kind of the last option. We flat out we intubate them. This bottom point here, the severely intoxicated or patient, the stroke with no gag reflex, again, those are the ones that they're going to be conscious at some point, and they're going to be a problem at some point. So that's a good RSI person with severe burns to inhaled burns. They're all of their structures are just going to continue to swell. All the soft tissue is going to, it's a traumatic event. So it's going to continue to swell. As it continues to swell, it's going to create more airway problems. Anaphylactic patients are the same way. Left untreated, that's going to continue to get worse and worse and worse until it's a complete obstruction. So the sooner you can take an airway from someone with inhalation burns or someone with anaphylaxis that you're not able to manage, the sooner you can take that, or even asthma for that matter, the sooner you can take that, the better off the patient's going to be, because the swelling will obviously have to stop around that tube, and you still have a patent airway at that point. So those are some of the big indicators for RSI. So if you have a national registry question or a FISDAP question that says very specifically you have a patient, you're evaluating a patient that was pulled from a house fire, and you see black soot in the nose and around the mouth, you can assume from that soot is because they inhaled some kind of toxic gases. And the answer for the airway is to RSI them and intubate them as quickly as possible, because again, that swelling is going to continue until there's no longer the ability to even pass a tube through. Hopefully that makes sense. Intubate. So the point here, so diabetes, overdoses, you can fix that and not need to intubate them, which is what we do in the field. Right now, we're doing a really good job in the pre-hospital world of intubating, or of just putting an OPA or an NPA in and just doing a BVM until Narcan takes over, or D50 takes over for the diabetic. Any questions on any of this so far? All right. Subcutaneous. So what we're when you start talking about adrenaline, we're talking about epi. So very specifically, this is given epi, sub-Q, or in our case, it'd be IM. Elderly patients, we want to be very, very careful of giving epi. So again, just in the scale of things I wrote on the board, we've pretty much covered all of the bases, all the way to intubation. If all else fails, and they're still conscious and you can't RSI them and you have to go the epi route, again, you give them the epi. That will facilitate the breathing treatment working, and that will facilitate you getting oxygen in. Very specifically, elderly patients, their hearts aren't super strong. They're deteriorated over time. They have comorbidities, so there's other stuff going on like heart failure and some other stuff that's already pre-existing. So when you give epi, you're essentially giving them an adrenaline shot, and that adrenaline shot's going to obviously increase the demand on the heart. All of that can create more problems to an already problematic patient. So a lot of times we got to be real careful with that. Now, the same with anaphylaxis. If they're going to die, if this is a life or death situation, so breathing, for example, if they're not breathing, they need epi. If anaphylaxis is going on and you can't open their airway, they're going to die from anaphylaxis well before they're going to die from the heart attack you're going to give them by giving them epi. So again, you have to fix the problem that is the immediate life threat. That's our job. So with these patients, if I can't get albuterol in, they're going to get epi. I just have to be cautious with the elderly patients. I got to make sure they're on a 12 lead. I got to make sure that I'm able to do some kind of aggressive airway management if they become unconscious. I got to be prepared to do CPR if that becomes a problem. So all of these things are they're factors. But again, go back to the very basic. We have to treat these patients for what's going to kill them. Before what I do is going to ultimately take effect. So again, they got to be alive to sue me. They got to be alive to cuss me out. So these patients that aren't breathing, they need epi, even if they are elderly. If that is the last ditch effort to open that airway, that's what you got to do. And that's something very, very specific that we have to really keep in the back of our minds. This also goes back to a lesser acute problem. and that's the albuterol. So if they're already having a hard time breathing, they're already going to be tachycardic. So if you get this elderly patient that's breathing quickly and their heart rate is 140, the last thing I want to do is increase their heart rate anymore. So by side effect, that's what albuterol is going to do. I know before I give it to them that it's going to increase their heart rate even more. So why would I give it? Well, the answer simply is you have to fix their breathing. And when you fix their breathing, that will fix, you have to fix B before you can fix C. So fixing the breathing will ultimately fix the C. It'll fix the circulatory system. If not, worst case scenario is they're alive and you've given them some kind of heart attack or something unforeseen, something that we can't predict. But what I do know is that if I didn't do that, they're going to die now. So again, it's kind of a hard pill for us to swallow as clinicians, knowing I'm going to stick this EpiPen in Grandpa's leg because he's dying of anaphylaxis right now. But I know that by doing that, I might give him a cardiac event later. So it's kind of a tough pill to swallow to think about. But again, if you do nothing, if you neglect to do anything at all, they're going to die of that anaphylaxis anyway. So you got to fix that. Putting meds down an endotracheal tube, that used to be a thing. We no longer really do it because now we can just drill them and give it IO. So we used to be able to give epi and atropine and some other things down an ET tube, and we don't do that anymore. So obstructions, I'm just going to keep on rolling through this. We've got a little ways to go still. So if you need a break, take a break. You can catch this later, as long as I'm recording this time, which I am. So I'm just going to keep rolling through. So patho, again, the tongue is the most common obstruction in the airway. I think we all know that by now. We assess that. We're going to hear probably some kind of snoring or some kind of stridor or something, leading us to know that this is an upper airway obstruction. A lot of times they're going to be obviously an increased work of breathing. This is going to be a more acute thing because it's an obstruction. So it didn't slowly happen overnight. They literally are choking on something. We're going to try to do a recovery position if we can. This is specific to these obstructive patients. They're going to try to lay in a recovery position if they're not on a prescribed CPAP. Again, this is all stuff that can tell us in our sample history whether or not we have some other pre-existing stuff. So if they have sleep apnea, they probably have some kind of palate. They're probably fat is really what it's going to come down to. And in a fat patient, we know that if we got to take an airways are going to be a little more difficult. Just in general, we know that there's extra tissue in there. The lungs are working a little bit harder. The heart is working a little bit harder to circulate the air, to the entire body. So these patients in general, that's a pretty big clinical finding for us, as far as management anyway. And the other thing, when you start moving into like this recovery position, that doesn't just obviously affect these obstructive sleep apnea patients. We're also talking about seizure patients or hypoglycemic patients, intoxicated patients, pretty much anybody else that's unconscious. We're going to put them in that recovery position, which is kind of up on their side. For us, we're a little bit higher level thinkers now. So in addition to that, we can put a nasal pharyngeal airway in. We can do some airway modification, just head tilt, chin lift, stuff like that. So here's some other stuff. Again, so moving from the obstructions, here's some other stuff that we got to consider and think about when we start talking about infection. So any kind of infection, a barking cough, 100%. If a test question asks you about a barking cough, it's going to be croup. And most of the time they're going to ask that related to a kid, but not always. This in a kid is called croup. This in an adult is typically considered more of like, it just slipped my mind. What is this in an adult? I'll come back to that because I can't remember now. Laryngitis. God, I'm retarded. Yeah. So as a kid, a barking cough is croup. As an adult, it's considered laryngitis. But essentially, it's just the larynx in the back is swollen. So that's pretty much that's going to be a cause of an upper airway for kids, some kind of swelling up there, something up top up here. So again, you might have some stridor, you might have some hoarseness in the voice, you might have that barking cough, and for these patients, typically we do nothing. There's really not a whole lot we can do because of the infection. Obviously, the airway it's open if they're physically breathing. We know that in some extreme cases, it could be argued that you could RSI and intubate these patients, but all that's going to do is create more trauma to the vocal cords and that glottic opening. So these patients just need a cool popsicles, a cool, calm ride to the hospital is really what they need. That cool air is gonna help with that. Occasionally, we can go a little bit deeper, and we can do something like nebulized saline. So if you just take a saline bullet and put it in a nebulizer, we'll give them just a nebulized saline, just to kind of keep that whole area kind of moist and able to just make it pliable. We don't want it to be rigid. We don't want it to be swollen and dry. That just leads more to the problem. So nebulized saline works. And then in severe cases, there's some protocols that will allow nebulized epi, or it's considered racemic epi is what it's called. And again, racemic epi, in a quick pharmacology update, racemic epi and the epi that you find for cardiac epi it's the same active ingredient, but those are two completely separate medications. So what epi that you pull out of the package, what you pull out of your drug bag and give for cardiac or for anaphylaxis or whatever, there's a beta 2 in that, and that beta 2 is what allows the bronchodilation to happen. There's also a vasoconstrictor, so it has an alpha property to it. That alpha property is what helps in all the other things that we use it for. When you're trying to nebulize epi, I don't want to affect the heart at all on these patients. I don't need to affect the vasoconstriction on these patients. I literally just need the beta properties. I just need the bronchial tree to dilate. So racemic epi is just that. It's epi, but it's epi without the alpha component. So it's only half of the epi that you're normally giving. It's chemically different. So a common misconception is that you can just take regular epi, stuff it in a nebulizer, and give it. Now, I'll also say that is exactly what we do, because we don't carry racemic epi. It just so happens that racemic epi by the manufacturer, it has to be refrigerated. So we don't have that ability for refrigeration on ambulances typically. So a lot of times we don't have blood products for that reason, and we don't have racemic epi for that reason. So we just do the best we can with what we have, and that's the regular ampule of epi that we give, the 0.3. We stick epi 1 to 1,000 in a nebulizer. You can dilute it. We'll get into that later with kids, but you can give regular epi through a nebulizer, and that will get it done. But again, just know that racemic epi is it's chemically different because it removes that vasoconstriction property. Poiseuille's law, that actually that's pronounced with a PW, which is kind of weird. But basically, this is the simple firefighter term. The bigger the hose, or I'm sorry, the smaller the hose, the greater the pressure. So likewise with a body, if a normal airway starts to become less voluminous, so the diameter starts to deteriorate, the pressure has to increase. So that's simply put, that's a term that's going to help us with the next couple slides here, or eventually here. So croup tonsillitis, we're still talking about some of these inflammations based on infection. Again, back to this. If there's infection anywhere in the bronchial system, it's going to start to compress the opening. And as it compresses the opening, the pressure has to be a little bit higher. So inhale pressure has to be high, exhale pressure has to be high. So management of that, basically, if it's some kind of obstruction, we use a laryngoscope blade, knowing that we can start to increase the problem. Any kind of trauma back there starts swelling. So, by us doing that direct visualization of whatever with a pair of McGill forceps to pull out an obstruction, we know that we're just going to create more trauma. We're going to create more swelling. So basically, the biggest thing we can do is we try to do our best. If you get to the point where you have to intubate these patients, If there's any kind of fluid or pus or anything in the back in that oral pharynx, a little bit of pressure from your partner on the chest can create some bubbles, and the bubbles that would give you a good idea of where that galactic opening is. And if all else fails, you have to go distal to it. So you have to do a cricothyrotomy. So aspiration, we know what that is. It can be food, blood, vomit, whatever else. It can be. They talk a lot about tube-fed patients because because they're tube fed because they don't have the ability to prevent aspiration. So if any of the tubing or any of the distal cuffs on the tubes become dislodged or deflated or something, they got a really high likelihood of inhaling. And basically, as they inhale or aspirate, that pretty much sits, whatever they aspirate, it sits in the bases of the lungs and starts to fester, and ultimately it becomes a pneumonia. So aspiration it does have a high mortality. Right, if the aspiration happened during eating or after eating or gastric feeding or something like that, that tells us pretty much what it is, and that would come out, that would show up with a sudden onset of shortness of breath and difficulty. And again, there's nothing we can do about it. So we do supportive care, keep the airway open, and get them to the hospital. Suction. So moving from aspiration to back to these, we're going to take a little bit deeper look into the COPD. We know that it's awful. So the biggest problem that we run into with the COPD, it is a complete obstruction of airflow in the lungs. So it does it a couple different ways. So again, the chronic bronchitis is going to put fluid in there. The emphysema is going to reduce the ability of the alveoli to physically accept any kind of air. We know asthma is obviously a very, very similar, it's a similar case, but without the fluid and without the damage. It's just swelling of normal tissue that pretty much creates the same problem. So protocol-wise, both of these tend to be the same protocol because it's the same pathophysiology. It's still a swelling in the airway. Now, whether it's a swelling in the airway by asthma reaction or whether it's a swelling in the airway because technically it's fluid and damage, either way, we're still having a hard time physically delivering oxygen. And that failure to deliver oxygen is why it's considered an obstructive disease. So with the COPD, it's irreversible. And if you still have notes for COPD, some more terms that you can add to it. COPD, it's chronic, it's progressive, and it's irreversible. So you don't come back from that. You just manage it the rest of your life. Asthma, on the other hand, is reversible. You can't cure them of having the next attack, but you can fix the one they're having today. The COPD, you can fix some of their symptoms today, but the problem still is underlying. The problem still exists. So in these obstructive diseases, the positive exhale, so when I forcefully exhale, this is where it kind of becomes somewhat difficult to kind of visualize. So the positive exhalation pressure causes some of the smaller airways to pinch shut. So as I forcefully under pressure blow out, the upper trachea and the upper main stem bronchi, they're going to exhale just fine. But the more pressure I create in here by pushing my diaphragm up, by physically forcing air out, is going to increase the pressure on the smaller airway vessels. So basically, just simply by exhaling, you're trapping air distal down here. So this oxygen, this carbon dioxide, physically cannot leave the airway because my exhale pressure is so forceful that it's physically occluded my airway. So with that said, if you remember the shark fins that I talked about with COPD patients, they have a prolonged exhalation, and they do that because the slower they exhale, the more air and the more molecules and the more gas they can physically evacuate from the lungs. So that positive exhalation, again, it pinches shut, it traps the gas in the alveoli. That stuff can't get out. They inhale, they add more to it. That can't get out. They add more to it. Again, it's a cyclical deal. It's a cycle there. So the harder they try to exhale, the more air is trapped in. So them breathing slowly and at a lower pressure is a more effective expiratory cycle. It works a lot better for them to exhale slowly at a lower pressure. And that's better than breathing normally. So if I take that end tidal tube and I stick it in my mouth and I blow through it, If I forcefully blow through it, I get that nice, sharp, crisp, square off that we're looking for in that waveform. These patients, again, they know that they have to breathe out slowly and they have to do at a lower pressure. So that's why you get that real slow, elongated, shark-looking fin. Again, because otherwise they're not going to be able to physically exhale all of this gas. So please make sure you understand that. If not, write that down, and we got to talk about it later. So they're going to have the pursed lips. Again, that pursed lip is going to help them prolong that exhale. There's going to be an increased ratio. They're going to be breathing really deep, really quickly. They're going to exhale really, really slow, and then they're going to quickly inhale again. Again, it's going to be a really, really slow exhale. They're going to try to use their abdominal muscles to kind of slow everything down a little bit. And again, you're going to have that jugular vein distension because you have all that inhaled air creating that high interthoracic pressure. And that interthoracic pressure, that starts to compress the vena cavas, and you end up having that backup of blood flow through the body. So similarly with asthma, you're going to have the airway edema a little bit, which is where they get the solumedrol. They're going to have the bronchospasms because everything's going to be tight and pretty much cordoned off there. And you're going to have that increased mucus production because again, your body is trying to rid it of a disease that isn't physically present. Asthma is a systemic reaction to various different things, but your body's way to do it, to deal with anything, is send fluid to it, increase the mucus production so that it can help flush out the problem and kind of clamp down so bad stuff doesn't enter the body. So asthma is really, we know asthma is just the swelling of the lung tissue. It does that because, again, it's essentially eating itself. It's trying to fight itself in a lot of cases. So, years ago, there's in 2014, for example, is what the book uses. In 2014, there were 24 million cases of asthma in the United States. That's exponentially increased because, again, we're dealing with more chemicals. We're dealing with more, some people would say pollution. Some people would say just in general, we have more awareness to some of the mild asthma cases that were otherwise untreated back when. So basically, we're seeing a big growth also in kids. Again, trouble breathing in kids. My son has kind of he has asthma, but he also has a reactive airway, which we'll talk about here in a little bit. And that's something that wouldn't have been diagnosed 10 years ago. So fatal asthma, we know there's different triggers. Certain triggers can be for asthma can be any kind of exercise. It can be infection. It can be all kinds of different stuff. Here's that reactive airway. So basically just any kind of environmental triggers, which is exactly what my son has. Any kind of environmental trigger. So ragweed and stuff like that will trigger him to have some type of asthma response. It's not full-blown asthma. It's just he has more bronchospasm. So he has more swelling in his lungs when he has these outside triggers than a normal person does. Very common, very, very common. And a lot of times they're asymptomatic between those attacks. So on a regular day, he can go play baseball and have no problem. But that one specific trigger will trigger a bronchospasm, and that airway is very reactive to that particular trigger. Status asthmaticus. This is huge for us. This is huge, huge, huge for us. Basically, this is a prolonged asthma attack that does not stop with conventional treatment. So the nebulizers at home have not helped. The rescue inhaler has not helped. These patients are dying right in front of you. This is the epitome of what pre-hospital paramedics need to be able to address. So this patient that has this asthma attack, that in the 4 to 6 minutes that it's taken you to get the call, get dispatched, show up, hasn't gotten any better. This should make the hair on the back of your neck stand up. This is scary. This is usually a kid, although it's not always. But you have that patient that just physically cannot kick this particular attack. It's going to continue to swell and continue to irritate and continue to produce secretions and continue to spiral down until they no longer have an airway at all. These are the patients that need to be intubated, which we probably can't do. Most of us can't RSI, but these are the patients that we need. We need something with these we need to be able to do the back-to-back treatments of albuterol. We need to be able to give epi. Epi is usually going to be the big fix for this in the pre-hospital world. Because we're in rescue mode. That is what that needs. He needs epi. Questions about that? Okay. So assessment. So the patient in this status asthmaticus. So again, we can't fix it. We're trying to look for infections. We're trying to figure out reasons that that we can maybe prevent or create or somehow create correct. A lot of times we're not going to find it. A lot of times this is an environmental problem that was left untreated, that they ignored for 20 minutes, a half hour. By the time they're making it to their rescue inhaler, their MDI, it's not necessarily working for them very well. So these patients are going to be struggling to move air because everything's obstructed. They're going to be obviously using the accessory muscles because they just can't get air in. They're going to continue to try to breathe in, but they can't exhale because now they're cramping off their airways with all that inner thoracic pressure. So they're not able to get those alveoli empty. So because of that, now they're maintaining that exhaled carbon dioxide that they can't exhale because it's getting trapped. So now their acid level is starting to rise. As you can see, this is just a full systemic problem. So they're not breathing well. They're now becoming acidotic. They're becoming dehydrated because their body's just shunting fluid to, well, everywhere to try to fix whatever's going on that it can't fix. So now they're dehydrated on top of everything. So there's like 3 or 4 different levels of shock that are happening all simultaneously here. So again, these patients are scary. These patients need epi like yesterday. They need IV. They need epi. They're going to need, ultimately, they're going to need breathing treatment. They're going to need steroids. They're going to need oxygen, all the stuff that we're going to be able to do. So with this patient, the very first treatment of this patient, for a test question, the very first treatment of a patient in status asthmaticus is epi. They need epi. They need epi right now. So you give the epi. Then you're still going to continue to do the basic stuff. So maintain airway. You're going to continue to assist ventilations if you can. You're probably not going to be able to get a whole lot of ventilations in because again, everything's so tight. And then ultimately you're going to need to bag in some albuterol if you can, or give them albuterol, have them take that albuterol in as that epi starts to work. And then ultimately they're obviously going to need oxygen because they're going to be hypoxic through all of this. Bronchospasm, we know what that is. Bronchial edema is just air being trapped, or I'm sorry, fluid being trapped typically in the bronchioles. This is all the same compounding problem. So moving back, they get the bronchospasm, they got the fluid secretions, they get the mucus productions. This is pretty much what it looks like as a diagram or as a photo. So the bronchospasm, if you look, it's tied like in a knot back in here. All the muscles that surround the bronchial tree, it's kind of a spiral. They all tighten and they all constrict. So the opening doesn't seem all that bad. But once you get to some of these choke points, they just physically are not getting a whole lot of air in. And this is the main bronchial tree. This is not even way down into the bronchioles. Way down in the bronchioles, this little bit of constriction is exponentially worse because again, there's not a whole lot of space in there to begin with. So edema is somewhat similar, where you get all the fluid starts to accumulate around and it starts creating pressure, and all of that fluid pressure ends up narrowing your opening. So again, management. They need a nebulizer for the bronchospasm. Ultimately, they need a corticosteroid to reduce the swelling and edema, and ultimately they need fluid to offset the excessive mucus secretion. This mucolytic agent, remember, this is Mucinex. This is not something. It's an expectorant that helps them cough. I don't have that. I don't need that. This is not a pre-hospital thing. So transport consideration, we need to get to the hospital pretty soon. Again, we need the IV fluids. We need ALS, which we can no longer play that card. I'd call for ALS intercept. Yeah, we can't do that anymore because we're it. And then let me go back one. What they didn't mention here was the end game. The end game is the epi. That end game is if they can't physically inhale that bronchospasm agent. So if we go back to the bronchospasm, if they can't physically inhale this nebulized bronchodilator, then we have to go to epi. That epi is going to open them up to accept this, and then we can treat all the other things accordingly. So for asthma, again, all 3 of these things need to be addressed. So they need fluid, they need a steroid, they need that nebulizer, and if you can't do any of that stuff, they need epi. So COPD, again, is similar. But emphysema, again, I said it damages the alveoli, and that's exactly what it does. But it also destroys that distal terminal bronchial structure. So the really, really tiny, fine bronchioles down at the very, very end, that it destroys those as well. So again, the surface area for oxygen to be able to be absorbed into the body is very, very low and diminishing. Um, what happens when some of them start to fail, the surrounding ones start to kind of come together and they form these little, they call them blebs, but basically it looks like a flower. It should be one nice bronchial, or I'm sorry, alveoli. But when they, like I said, when they start to damage, they kind of mutate and try to combine together to create big ones. But that doesn't necessarily work that way. So what these people end up with, if I had a scope and I could send it down a COPD patient's airway down way into the bronchioles, instead of all these nice little bubbles that are set up ready to accept, you get all these like clustered ones that are kind of formed together and kind of mutated all weird, and they don't have the ability to physically bring in that oxygen again. So that it affects gas exchange. And then when all that happens, the obviously the tracheal, the bronchial tree starts to they call it stenosis, but it starts to harden. And as it hardens, it's less pliable, and it basically starts to kind of die off, and it dies off from the inside sort of out. So these patients, again, they need very, very cautious care because again they can't exhale. So for a COPD patient that becomes a non-breather, if you know that they have COPD, your breath, you physically are breathing for them. When you give that ventilation, it's going to go in, it's going to stall out in air, and then as that passive process starts to exhale, you have to give them time. You have to give that lung that you have to give that mediastinum time to decompress. Otherwise, all you're going to do is continue to pump air in that's not coming back out, because again, everything is destroyed and everything is being cramped off by the pressure that you're given. So if you increase that intrathoracic pressure with your bag squeeze, again, knowing that there's going to be a delay in exhale simply because of the pressure that you instilled into their chest with the bag. So just know that there's going to be a decrease in return. And you'll be able to see that very clearly on a capnography. You'll be able to see that prolonged exhale where it's taken their body a little bit of time to physically get rid of that air that you just put in, or that pressure. So chronic bronchitis, we talked a lot about that already. I don't want to go back into that too heavily. So again, these patients, they're usually cigarette smokers, heavy smokers. They're usually overweight. Chronic bronchitis, they're usually congested. And sometimes they kind of have a bluish complexion to them. So the test, or a test someday, pink puffer is the term that they like to use to describe the emphysema patient. They're going to be, again, they have that excess red blood cell production. They're going to kind of have a pink hue to their skin, and they're going to be puffing. They're going to be trying to slow that exhale. So pink puffer. The chronic bronchitis, they call them blue bloaters because they're usually kind of cyanotic, because again, they can't get oxygen where it needs to go. They're generally hypoxic, and they're bloated. They're usually heavy set. They're overweight. They're congested. They consider them like a blue bloater. So emphysema, again, barrel, and we're kicking back and forth because again, these are the same. These go to the same COPD diagnosis. So emphysema, again, that barrel chest, because they have that chronic hyperinflation that they can't exhale enough. They're breathing quickly. They use a lot of a lot of their intercostal muscles to try to breathe. So they have that barrel chest. With the COPD patients, a lot of times they do have that diffuse wheezing because again, everything is swollen, everything is cramped off by them just simply by nature of breathing. So wheezes are the sounds that you're hearing from those collapsed bronchioles. So when that alveoli is trying to empty out, but it's being restricted, that noise of that air passing through that restriction is the physical wheezing that you're hearing. So when we go back to this picture, air passing through this exhalation cycle, this is usually where that wheezing happens. And again, it's air being forced through this crimped off section in the bronchial tree. Hopefully that makes sense to everybody. Mm, localized wheezing. This is unrelated. Again, localized wheezing is something very, very specific to one thing in one spot. You won't hear that in the other lung. So COPD with pneumonia. So this patient, the likelihood that this patient will walk out of the hospital, it's possible, but it's low. COPD patients don't have the ability as it is. So you add an infection to it, you add swelling as secondary to the infection. That's a huge deal. So again, fever and pneumonia those should link together in your brain. That should absolutely be a thing. If they have all of these symptoms without a fever, it's COPD. But if they have all these symptoms with a fever, we're thinking infection. So remember pneumonia. Pneumonia should be linked to fever in there. And again, they ask one question, and everybody always argues the question. And it's that question about the pink frothy sputum, which we know should be related more to congestive heart failure, but it's pink frothy sputum with a fever. And the question is what is most likely the cause of the inflammation. And it's not congestive heart failure. It is 100% pneumonia. And everybody argues that question, and usually 100% of the class will get it wrong. So be cognizant. Remember, fever and pneumonia should go hand in hand. This says breath sounds are consistent with pneumonia. It's consistent until you get down into the bases. Down in the bases where whatever created the pneumonia, whatever the infection, whatever the aspiration is, that all went down into the bases. It settled in there and became stale. And as it became stale, it started to become infected, and that infection ultimately manifests as pneumonia. So these COPD patients, we know that they're going to have right-sided heart failure. We talked about that earlier. It's because, again, it's important to reemphasize because you got to understand it. When with COPD, again, they produce more red blood cells to try to compensate for the oxygen lack. The heavier quantity of red blood cells thickens the blood, physically trying to force thick blood through the capillary beds and through the alveoli, very, very difficult, which creates a strain on the right side of the heart. So again, those patients are going to have all of this stuff. A lot of times with this right-sided heart failure, all the fluid's going to back up into the body, and you're going to have that jugular vein distension because you're going to have that interthoracic pressure, and you're also going to have that pressure is going to restrict the blood flow back to the heart from the vena cavas because there's so much pressure in there. So you'll see the jugular veins. COPD with left-sided, that's pretty much the same, just a different part of the heart. I'm not going to mess with that. So exacerbation of COPD. So this is our treatment. This is us. So COPD is not something we diagnose. It's something a patient lives with. They're going to tell us I have COPD. But suddenly something happened and they're having a hard time. It could be environmental. It could be asthma on top of this. It could be infection. It could be something like that. And again, our treatment is going to be the same. It's going to be, they need oxygen, but can they take oxygen? If there's wheezes, they need the bronchodilator, and then down the airway, down that algorithm. So end stages, the lungs can no longer accept anything because what's left of the alveoli are those little blebs. Those start to deteriorate, or those start to get overused, or those start to get so filled with oxygen that when they exhale, that pressure within that alveoli sac, eventually those little sacs will rupture because there's too much pressure in that cannot escape. They can't get out. So eventually those will start to rupture, and those will start to deteriorate, and these don't regenerate. So when you lose your alveoli, you lose them. So as those start to degenerate and pop, and when those start to deflate, that we start hitting the end stages where they physically can't oxygenate at all. And there's really not a whole lot that we can do for that other than start doing, their DNR stuff with them. We know that 90% that might be normal for them. The likelihood of us getting to 98% is not likely with COPD because they're chronically hypoxic. Take them to the hospital. Hypoxic drive, we talked about that. You got to understand this. Make sure this is written down somewhere. With hypoxic drive, their stimulus comes from a decrease in oxygen rather than an increase in CO2 like you and I. So make sure that makes a ton of sense to you. And by the way, a lot of this stuff, they're going to ask questions based on this in your FSDAP exam coming up. It's all going to be based on these theories, but they're just going to be worded in with patients. So the patient's going to present with whatever. Your patient complains of sudden onset of shortness of breath. What's the most likely cause, and things like that. So, and we'll kind of summarize everything here in the next couple slides. But know that this. So your patient is hypoxic, or your patient is you've got a COPD patient that isn't responding to high CO2 levels. Why is that? It's because their body doesn't respond to CO2 levels at all. It's their oxygen, they're hypoxic driven. So there's a big difference there. Sometimes it says it's impossible to tell, which is also true. But if they tell you very specifically that they have a hypoxic drive, that just means that literally their drive to breathe is from hypoxia and not from hypercarbia like you and I. Let's skip through some of this. Auto PEEP. So PEEP is the term referred to. It refers to the decreasing the expiratory pressure. So these COPD patients, they need to forcefully exhale, but they can't. So PEEP is essentially their way of restricting the flow, or restricting the pressure rather, so that those airways don't collapse all the way. So PEEP is something that we usually see on ventilators. So this is basically like the blow-off valve. This is the valve that prevents too quick or too forceful exhalation. Sometimes they can use these to prevent too rapid or too deep inspiration. Pulmonary infections. So moving out of COPD, we know infections cause pus. Pus causes airway compromise because it covers the alveoli and prevents air from hitting it. Again, alveoli can be non-functional and filled with pus or pus or water or fluid or anything else. Alveoli becomes non-functional. Skipping through some of this because we've talked about most of this. Greater risk of pneumonia, elderly people who smoke. We know all of that. Taking a history, they've got a productive cough. There's the word fever. The word fever means infection. Infection, when we're talking about lungs, is usually some type of pneumonia. I guess it'd be fair to also mention that acute bronchitis, so not the chronic bronchitis that we've been talking about with these blue bloaters, the people that we've already talked about today. The acute bronchitis, so somebody that has an airway, some kind of upper respiratory infection, what you and I would usually get, that upper respiratory infection can occasionally present with a fever. The big difference, so the difference between them all, or between the acute bronchitis and the pneumonia, is if you think about pneumonia, that's going to live in the base of the lung somewhere. So you'll hear decreased breath sounds in one lower lobe, where the acute bronchitis is pretty much it's a global thing. So it's the entire bronchial system is infected. So pretty much everywhere anywhere you listen you're gonna hear crackles. You're gonna hear that kind of stuff. So a lot of times that is the differentiation between acute bronchitis and pneumonia. Again, pneumonia is that isolated junky lung sound. Can be acute or gradual. I'm gonna skip through some of that. We know that pneumonia usually occurs in the base of the lungs and usually on one side. So again, oxygen saturation could be significantly lower if we put a patient on that bad side, because again, just by nature, it creates the absorption problem. Really supportive care for us. We just give them oxygen, we suction them, and we get them to the hospital. They need antibiotics, and we don't have that. So obviously it needs aggressive management, but again, that's going to happen at the hospital and not with us. As far as the alveoli, again, if it's filled with pus, water, fluid, whatever, blood, or smoke or something damages them, obviously they're not going to work. We talked a lot about that already. So there's that atelectasis word again. So atelectasis, write that down. So basically, atelectasis is essentially just a term that just means it's an acute non-compliance of the alveoli. So it can be because it's occluded, or the alveoli because it's occluded, because it's covered in fluid, because it's somehow part of the lung has physically collapsed in on itself. That can all be reasons for atelectasis to be apparent. So again, a lot of atelectasis all that simply means is it's a temporary stoppage in the actual compliance of the lung tissue, which ultimately that dead space that's formed in there can give you that chance of pneumonia because there's nothing moving in or out of it. Here's a more pronounced. We know that affected area can harbor the pathogens that cause pneumonia. Simply put, management of atelectasis is to try to keep that lung tissue open. So post-surgical patients will get this incentive spirometer, where they have to try to blow the ball up. There's a couple different uses for this, but again, at the end, the core is just to keep that lung tissue open and compliant. So outside of that, those are the normal things. Some of the abnormal things they want us to talk about cancer. Again, cancer basically all that is going to continue to get through and create either a tumor of some kind. The biggest thing with cancer is any kind of abnormal growth in the lungs. They're going to probably try to find a way to biopsy, and chances are in the lungs there's not a whole lot of different tumors that grow in the lungs that are non-cancerous. There are some, but most of the time the first thing they're going to see is this vomit in their blood, which for us pre-hospital, if we see that vomit in the blood, like that's that blood streaked sputum. So immediately we're going to think maybe something along the lines of like that tuberculosis or something like that. But with cancer, it is a thing. They usually know they have this beforehand. But it does often metastasize into the lung from somewhere else, because again, there's not a whole lot of way for just rogue cells or cancer cells to accumulate in the bronchial tree. So a lot of times it comes from outside the lungs and affects inward. There's really nothing that we can do for any of this. So I'm going to skip through some of this. There's very little things we can do. Pleural effusions is really just it's an excessive amount of typically air in the lung tissue area outside the lung where it doesn't necessarily belong. But again, that's all. We'll talk about that too in a sec. Nothing we can do for cancer. Toxic inhalations, again, we can't do anything about that. The test questions will be worded very specific to they breathed, they inhaled some kind of toxic gas. Now they're having trouble breathing. What do you do? And really, the only thing we can do, we can assess and figure out what it is, make sure we're safe to go in there. We basically, there's not a whole lot we can necessarily do other than do the basic airway management. We can intubate them early if possible. The place you're going to see this is this top point here. This is not uncommon. People use bleach as a cleaner. They'll try to use drain cleaner. They'll pour Drano or something down the drain. They won't flush it with water first, so they'll pour the drain cleaner and then they'll clean the sink with bleach. And that creates a pretty awful chlorine gas. So this can actually be fatal, but this damages the alveoli just the same as a house fire would, or the hydrogen cyanide from a house fire would. So chemical, again, this is just chemical burns, chemical inhalations. Again, the only thing that we can really do, give them 100% oxygen, intubate them if we need to, breathe for them if we need to, and try to get them to the hospital as quickly as possible. Pulmonary edema, again, there's only like three of these left. And again, these are all just the common things we're going to see. I spent a lot of time on COPD and asthma because they're the most common things we're going to see. These are the lesser ones. So like pulmonary edema, again, this is usually a byproduct from the COPD or from congestive heart failure rather. But typically it's just blood plasma. It's just fluid that enters the lung tissue. There's a couple different kinds, and I wouldn't worry too much about the different kinds. Just know that any fluid in the lungs, it's going to prevent the alveoli from working and the gas exchange won't happen. So any kind of pulmonary edema, the biggest thing is for us to do is try to get the fluid out of there. Again, we do that basically by trying to put them on a CPAP. And this is still going through diagnostics here. You're going to hear the crackles in the lungs. There's going to be some swelling, which leads to the fluid accumulation, which leads to us hearing them through our stethoscope. There's going to be kind of some of that watery sputum. Sometimes there's that pink tinged. There could be the frothy sputum, and again, pink frothy sputum without a fever is usually heart failure. So you can appreciate all that stuff. And this is, and basically with that, the only thing we can do is CPAP them. So we try to CPAP them. We put that continuous positive pressure into the lungs, try to keep them open the best we can. So CPAP, nasal intubation would work for these patients until they stop breathing, and then we go down the not breathing route of intubation or whatever else. So again, CPAP is it's underutilized. If you starting today, if you start looking in the field, you get the trouble breathing call, you're going to start looking at it hopefully a little bit differently. Specifically our COPD patients that are the run-of-the-mill patient for us, or the asthma patients. Now you know kind of what's going on, what's happening. When you're sitting in the back and you're just kind of the third party or the fly on the wall watching the medics work, start looking at how underutilized CPAP really is. Think about all the patients that you've had that have had wet lung sounds that didn't get CPAP'd. It's probably more than you want to even admit. And you'll see that from now on. If their lungs sound crackly and there's fluid in there and they're obviously short of breath, with or without the hypoxia or with or without the actual SpO2 changes, if they're having a hard time breathing and they got fluid in their lungs, those go together. They have trouble breathing because they have fluid in the lungs. So the first line treatment for that is CPAP. Open that up, push that fluid out of there. And again, you'll start to find out that it's more hassle than not for some of your people to actually do that. Sad reality, but that's true. And that's kind of the difference between an aggressive paramedic and a not so aggressive paramedic. This is ARDS, ARDS, acute respiratory distress syndrome. We don't see this very often. This is a whole nother world of stuff. The biggest take home from this, there's only 2 slides that cover this. The biggest thing when there's diffuse damage to the alveoli from some of this other stuff. So again, shock, we aspirate all the gastric acids, and the acids from our own stomach start to damage the alveoli. Again, this did not come over time. This did not come from chronic smoking for 20 years. This didn't come from being sedentary and having bronchitis once a week for the last 12 years. This is a very, very isolated acute incident of some kind of damage to the alveoli. That particular thing is considered an acute respiratory distress syndrome. And really for us, we can't do anything different. Chances are in the field, we're not going to even notice that this was a thing. We're just going to know that they were acutely short of breath. And actually with that, we're going to think one of the next 2 things is the problem, not necessarily this. We're going to think that it's maybe a pneumo. And again, a pneumo, we talked about a pneumo already. A pneumothorax is just it's a deflation of the lung. So air starts to collect in the pleural space. These COPD patients that have the weak spots, or those blebs, those accumulated, those fused together alveoli, those weak spots can absolutely deteriorate into a hole. And when that hole forms in the lung, again, you have a pneumothorax now. You have air that goes right out of the lung into that interstitial space, or that pleural space. So again, that can be caused by something as simple as coughing for these patients. Just a forceful cough could absolutely deteriorate this to the point where it ruptures. So a lot of times in pediatrics, we'll talk about a simple pneumothorax, which is basically if there's a 16-year-old, for whatever reason, a teenage, tall, lanky patient seems to be like all the inclusion criteria for this. But if you got a 16-year-old that was playing on a basketball court and became acutely short of breath, that is a really, really, really high indicator that is what's wrong with this particular patient. It's a pneumothorax. So before you got to that, you'd have to go through the different criteria. So your differentials. So a 16-year-old on a basketball court, you're thinking maybe asthma. If they don't have any history of asthma and they're extremely or profoundly short of breath, there's really nothing else that could be. If it's not, they were fine 30 seconds ago and now they're not. So again, it's something that happened right now in front of you. So again, you got to rule out asthma, but if it's not asthma, chances are it's a pneumothorax. And again, tall, lanky, teenage person is usually what the test question would be. So that's a high indicator of that, of a pneumothorax. So those patients, this is not an acute treatment per se. They just have this coughing, they got this pain, they got this short of breath that happened almost immediately. We got to get them to the hospital. There's really not a whole lot of acute intervention that we're going to need, because they're going to need to go back in, take that lung tissue and put it back where it's supposed to go, and that will fix their problem. Left untreated, this pneumo does become a tension pneumo. That air accumulation will continue to fill that pleural cavity until it starts to create problems. And once it creates a low blood pressure and a high heart rate and all the other respiratory problems, those are the patients that we have to try to decompress them. And again, we'll talk about that sort of later. Pleural effusion was something quickly talked about, but basically this is a big blister. It's a big sac of air or fluid or pus or something that forms in there. And you can see that obviously takes up space in there. Again, we're going to hear breath sounds up here, where with the pneumothorax patient, you won't hear breath sounds on one side at all because there aren't any. So these pleural effusion patients, again, you're not going to know necessarily about that, so I wouldn't worry too much about that. And the very, very last thing that we got to talk about is this pulmonary embolism. And this is it for the day. So we talked about COPD, we talked about asthma, we talked about pneumothoraxes. And those are probably, in addition to this one, those are probably the top four, not necessarily in order of acuity, because this right here, pulmonary embolism, will kill them while you physically have them. So that's not going to be something that I would worry too much about. You'll know right away when this patient presents. They will physically show up. Basically, a blood clot broke off from somewhere, some kind of fat embolism, something broke off from somewhere in the body, lodged itself in that bronchial tree, and it completely prevented blood flow back to the heart of the oxygenated blood. So this is huge. This is huge for us. These are your non-breathers that show up. A lot of times, it's really, really weird wherever that clot is anatomically in the lungs, wherever that physically ended, there'll be a very, very distinct line, usually, where everything above that line all the way to their head is blue. So you can look at these patients and you can look right away and say, that's probably a PE. They've got this very distinct line. Everything above the line is blue. Everything else is like a pale color. It's a very distinct line. They threw a clot somehow. A clot went from somewhere, lodged into that bronchial tree, and now again, oxygenated blood can't make it to the heart, and they die. So there's really not a whole lot we can do about these patients. They at times there can be a partial blockage, so they'll call 911 because all of a sudden they can't breathe, like at all. They can't breathe. They don't know why. They can't get air in. We'll take them to the hospital. They might be status quo the entire way to the hospital, and physically moving them from our cot to the hospital bed, just that is enough for it to simply finally to completely occlude, and they die right there on transfer. And again, there's nothing we can do about this. So there's really nothing. There's nothing that we can do. We can't oxygenate them anymore. We can try. We're going to work it like any other code, but there's really nothing you can do, because again, there's been a complete lack of blood flow now to this particular area. There's a clot, and that's pretty much that's it. Some of the risk criteria, and I only got a couple minutes left, and that's good because we only have 2 slides left. But some of the risk criteria for this: females, specifically childbearing age females on birth control. Birth control, for some reason, that there's a couple reasons, but basically that it gives a higher likelihood of having clots in the body. Those particular clots, again, once they break off, they lodge in the heart. It's called a heart attack. If it lodges in the brain, it's called a stroke. And if it lodges somewhere in the bronchial tree, it's a pulmonary embolism. But at the end of the day, all 3 of those are all blood clots that's got sent off and lodged somewhere, creating a blood flow problem. So again, depending on where it goes is where the problem is going to be. Changes in pressure. So people that just landed in an airport and they have an acute shortness of breath, there's that intrathoracic pressure that happened. There's a change in pressure. That change in pressure has the ability to, there's a part of the heart that doesn't send, and we'll talk about this in cardiology, but there's some stale blood that sits that's left unpumped or not sent out. That can absolutely throw a clot out. People with AFib, we'll talk again about that. people hiking, again, just elevation changes, barometric pressure changes, and stuff like that. The most common one that we're going to see though is people with diagnosed deep vein thrombosis. So they have vein problems in their like distal, like in their legs, and they have some kind of injury pattern or some kind of deep vein thrombus. That thrombus can break off and get sent somewhere else in the body. And again, if it lands in a bronchial tree, it's a PE, and it is fatal. So there's really nothing we can do. A greenfield filter is something that they put in superior to the thrombus sites in the legs. Basically, it's just a big net, and it catches anything that goes up the leg. But again, they have to be diagnosed with that before they can get something like this. So really, there's nothing we're going to be able to do. They're going to catch that embolism depending on where it is. If it's high in the tree, that's probably fatal right away. Otherwise, it's just an acute shortness of breath until they go in there and find it. So that's it. That's pretty much it. And that covers all of the major ventilatory problems, all the major respiratory problems that you guys are going to come in contact with. I don't have anything else for you guys. I know Tuesday is going to be a lab day, and then Friday, like I said, we're coming down to the end of the term here. So Tuesday is going to be kind of a catch up. It's going to be kind of a review. We are going to do, we'll do the trach scenario, or the cricothyroid. We'll do the cric scenario with the pig trachea. That'll be kind of cool. That'll be neat to see. And then it's going to be kind of, it might be more of a study session that we'll kind of go through. The morning group, hopefully the morning group has some pretty decent questions. The problem that I'm going to struggle with is whatever comes up in the afternoon, the morning group won't have access to the answers to that. So as questions come up, if we do like a formal study session, I'll write them all up on the board, all the points, all the questions. And then at the end of it, I'll just take a picture of it and I'll send it out to you guys. In the next probably hour and a half, you got check your email. You guys will have a study guide of sorts. It looks a lot like FISDAP type questions with the answers on it. Use that as you will. They're not going to be the questions that are on there. The questions that are on there are in the study guide that you guys have already worked on. Those are actually the questions that are going to be on it. They're the general things that are going to be on it. And other than that, I think that's really about all I got. If you need something else, hang around. Everybody else, feel free to head on out, and I'll see you guys Tuesday.